Iridodialysis, also known as core dialysis, is a localized separation or tearing away of iris from its attachment to ciliary body. Iridodialysis is an infrequent complication that can happen during nucleus removal by sandwich technique in manual small incision cataract surgery. Apart from iatrogenic cause, trauma is the most common cause of iridodialysis. Large iridodialysis leads to cosmetic blemish, uniocular diplopia, unwanted visual phenomena like glare. Iridodialysis repair is indicated not only for cosmesis but also to reduce visual phenomena.
A 54-year-old patient who was operated 2 weeks before for cataract surgery elsewhere
presented to us with 270-degree iridodialysis, aphakia, and with no capsular support. Fundus examination shows no lesions in the retinal periphery. This patient underwent iridodialysis repair and scleral fixated IOL. This video demonstrates repair of large iridodialysis. Conjunctiva in the area of iridodialysis is cut near the limbus. A side port is created diagonally opposite to the suture entry point. Needle entry points on the sclera 1.5 mm from the limbus is marked in the area of iridodialysis using caliper. One of the needle of the double-armed 10-O proline suture on a CIF4 needle is passed through the paracentesis and then through the peripheral iris and out of the sclera 1.5 mm away from the needle, guided by the 26-gauge needle. Second needle of double-armed proline is passed through the same paracentesis needle through the peripheral iris adjacent to the first needle, guided by the 26-gauge needle. The two suture ends are tied with a 311 surgical knot. Subsequently, rest of the iridodialysis repair is done with a single-armed proline on a CIF4 needle to avoid utilization of new suture for each fixation. A single-armed 10-O proline suture on a CIF4 needle is passed through the sclera 1.5 mm from the limbus and then through the edge of iris and out of the paracentesis incision, guided by the 26-gauge needle. The same needle is then again passed through the same paracentesis incision and then through the sclera 1.5 mm from the limbus adjacent to previous suture. The suture ends are tied in a 311 surgical knot. Similar procedure is repeated for the other two sides. scleral fixated IOL was implanted at the end of the iridodialysis repair. Conjunctiva was closed with 10-0 nylon suture. These are the pre-operative and the post-operative picture of the same eye. To summarize, iridodialysis repair is done using a double-armed 10-0 Prolene suture. Peripheral iris is fixed to the sclera 1.5 mm from the limbus. The number of fixations depend on the extent of iridodialysis. This eye required 4-point fixation to achieve a relatively round, cosmetically acceptable pupil. We have successfully managed a large iridodialysis result in more or less a circular pupil. BCVA in operated eye was 6/9 N6 3 weeks after surgery. Thank you for your patient hearing.